Good morning and welcome to our seminar this morning, The Syndemic of Mood Disorders, Medical Comorbidity, and Sleep Disturbance. I'm Roger McIntyre, psychiatrist based in Toronto. I start off by saying good morning, but we have people joining us from many different time zones for our program this morning. Welcome. We've got 2 hours together, an ambitious schedule. We're going to be talking about the management of depression and sleep in the context of COVID-19. You're going to be hearing a lot of conversation about stress, screening. You're also going to be hearing a lot about solutions during the next 2 hours. So glad you could all join us. You all have received in your emails, you've received copies of today's slides, the enduring materials for today, and you also in fact have the bios of each of our speakers this morning, and I'd encourage you to have a look at those bios. I want to thank the sponsors who've made this program possible. The partnership with the private sector has been critical for us to have not only research and development in psychiatry, but also, in fact, the opportunity for high quality knowledge transfer, which is indeed what we plan to do today. So thank you for all the sponsors for your support. Again, you have the bios. This is a very nice pictures of each of our faculty and their affiliations, and I'll certainly introduce each of my colleagues and our speakers just prior to their presentations. Now, the education program objectives are listed here. What we really want to do is really cover aspects of depression, but also sleep, and a topic of particular interest, that being medical comorbidity, very commonly encountered scenarios. And I think, if anything, COVID-19 has laid bare, it's also exacerbated some of the social determinants and some of the diseases that are related to stress that we're going to be talking about this morning. Now, just a quick housekeeping issue. We've got a big audience today. We've had large audiences for each of our programs in the hundreds. So we've turned all your microphones off to keep the dogs from barking in the background and so on. And you, in fact, can submit your questions. Don't submit through chat. Submit through the Q&A panel on the Zoom control bar at the bottom. Now, if you in fact submit Q&A, or if you see a question submitted, you can vote up that question if it's a question that you would like to see addressed by the speakers. Because we're going to have a lot more questions than we have time for, we really democratize the process, wherein if someone submits a question that you'd really like to push up to the front of the line, you can vote it up with the thumbs up icon. This is the agenda. We're going to start off with a broad sweeping look at depression and preliminarily look at some of the initial treatments for depression and bipolar. We'll narrow the focus into treatment-resistant depression. Then we'll speak to this very, very common scenario we find ourselves in, that is managing mood disorders in pregnancy and postpartum, get into a discussion around sleep, and then we'll finish off with medical comorbidity and depression, followed by Q&A. Let's begin, if we can. This is the disclosures of organizations I work with in the private and public sector. Now, if anything, what we can take away from COVID-19 is the recognition of the hazards of chronic, unpredictable stress. As organisms, we are remarkably resilient to acute and chronic stress. We're less resilient when it comes to chronic, unpredictable stress, when the agony end line is uncertain. And cuss certainly makes us all want to cuss. This was a study just recently published in poor kids living in poverty in the south side of Chicago. These investigators told us that when you live in a context or in an environment of chronic, unpredictable stress, it changes your brain's function. In other words, it changes regions of brain responsible for emotion, for enjoyment in day-to-day life, and also fear, as evidenced in this slide by increased amygdala activity in children of poverty. What's the point of this? The point of this is, in fact, to bring our attention to mediators. The New York Times has made the word languishing the word of the year. As clinicians, we see people with new onset and exacerbated anxiety, depression, insomnia, and weight gain. And we're all asking our questions, how can we help our patients? And helping patients begins with asking a fundamental question, what's causing this? And there's convergent evidence that some of these changes are due in part to immune dysregulation. Our patients with mood disorders have not just common and debilitating disorders that exact immeasurable costs, but they are also at greater risk of a variety of medical conditions. Many of you may have heard, but for those who are less familiar, having a diagnosis of depression or bipolar disorder will increase your risk of contracting, being hospitalized with, and dying from COVID-19. In this analysis by one of our students in our team, Felicia Saban, she demonstrated that hospitalizations and death due to COVID-19 is on the increase. Now, at first glance, this certainly brings up aspects of social determinants, but also in my own mind begins to also converge on this point around immune dysregulation. We know from other lines of research that people with mood disorders have an attenuated response to vaccines. These are vaccines before COVID, something we'll have to keep a close eye on during this COVID era. All of the international large media outlets, including but not limited to The Economist, the Wall Street Journal, the BBC, covered this report from the UK Biobank just this week. They reported in a very large sample, 40,000 people initially MRI'd, 1,000 repeat MRI'd, some with, some without COVID-19 infection. It turns out that COVID, at least something about it, is promoting apoptosis of gray cells and of white matter cells. It's tempting to think that this is a direct toxicity of the virus. A non-mutually exclusive hypothesis could be this is related to cytokine or so-called cytokine storm. The entire world has had a minor degree, if you will, in immunology the last 16 months. We implicate some of the more hazardous cytokines like interleukin 1 and 6, but I always like to highlight QA. Whenever I think about QA, I think about quality assurance. That sounds like a good thing. But QA in the world of depression and bipolar and stress is not a good thing because QA is an acronym for quinolinic acid. And quinolinic acid is one of the most toxic consequences of activated immune systems. Quinolinic acid is elevated in depression and bipolar and causes loss of brain tissue in the same reasons we're seeing some of these findings in COVID. By the way, this fall, our team will be launching the first randomized controlled trial looking at an antidepressant to treat what's called the PAC-19, the post-acute COVID-19 syndrome, better known as the long hauler syndrome, which is phenotypically overlapping with myalgic encephalitis or chronic fatigue syndrome. So an amazing syndemic of public health and also mental health aspects that are converging. Now, when a patient presents in the clinical ecosystem with depressive symptoms, I don't think that the detection of depression is that difficult. Everyone's expert in detecting depression. The question really is do they have bipolarity? And all patients should be screened for bipolarity. You want a screening tool that's brief, sensitive, has good negative predictive value. That is, if they screen negative, they in fact do not have the condition. You also want a screening tool that doesn't have false positives at a rate that are problematic. The MDQ is a well-known screening tool that has many of these aspects, but unfortunately has a very high rate of false positives. Perhaps this is why about 85% of people in a recent survey I completed of American healthcare providers know of at least one screening tool for bipolar, but only about 25% implement them. We validated the rapid mood screener with a view to hold on to some of the positive of the MDQ, but in fact to reduce the false positive rate so often seen with other screeners. And this is, by the way, free of charge, good price. We'll send you a copy of this screening tool after the program. Now, when it comes to making the diagnosis of bipolar, it goes down to the what's called the illness validating factors. What's the age at onset, number of episodes? Of course, we put tremendous currency into the family history and response to treatment. Nothing has changed. What we also need to think about is the phenomenology. And I'm going to leave you now with a couple of just really bedside tips. Everyone knows psychosis and atypicality is more common in the adult with bipolar depression relative to major depression, but also want you to think about the 4 A's. And I've written on mixed states throughout my career. It's something I've had tremendous interest in from a historical, nosological, therapeutic perspective, but I've really tried to understand what are the symptoms of mixed and how can I disambiguate mixed from mania and depression. The 4 A's refer to anxiety, agitation, anger, and attentional problems. When someone comes to my office and says, I'm anxious, I'm agitated, I'm really angry and irritable, and I can't focus, I've got terrible ADHD, that makes me very suspicious that the underlying diagnosis is bipolar. We know about 25 to 40% of people with bipolar depression present with mixed. So be on the suspicion, if you will, for bipolar in such a presentation. If your initial consultation is major depression, you don't know for sure if it's pseudo major depression. And Josh is going to speak to treatment-resistant depression in a moment. And I suspect Josh would agree that in any patient who's presenting with major depression, who's not benefiting from conventional antidepressants after, say, 2 years, 3 years, even 5 years, don't forget to rethink the diagnosis. This is what I call the 1 to 2% rule. If I had 100 patients in my office today, and I said, your diagnosis is major depression, and here's a prescription, come back in 10 years because I'm very busy. That's my next scheduled follow-up appointment. When they come back 10 years from now, 10 to 20 of them now have bipolar disorder. This is Mother Nature's fault because you know that depression is not only polarity predominant in bipolar, it's polarity first, and it's also polarity at entry. And we wouldn't know that these individuals have bipolar unless we're longitudinally keeping our minds and ears open for that possibility downstream. Now, it's not my intention to go through all of the treatment strategies for bipolar, only just to give us a bit of a sampling. Acute mania, second generation antipsychotics are not only treatments that are de facto, but also de jure. In other words, these are the first-line treatment strategies in outpatients and inpatients in mania and mixed. For maintenance, well, the guiding principle of what gets you well is what keeps you well is not always true, but it's usually true in bipolar disorder. Where's the money at in bipolar? It's in depression. Let's look at the drop-down menu here in the far left, and I want to leave you with yet another maybe little acronym here, which I call the 3 L's, that being lamotrigine, lurasidone, and lithium. They remain the first-line treatments for bipolar depression. And I'm speaking about bipolar 1 depression, and in most cases, I'm also thinking about bipolar 2 depression. If single monotherapy L is insufficient, we'll often combine L's together. Where are the conventional antidepressants? They're very popular in bipolar depression. In fact, they're the second most frequently prescribed class of drugs in adults with bipolar depression. Not on the list, not FDA approved, and so not been established as unequivocally efficacious. In bipolar 2 depression, I'll just put this out there for now, there's a story unfolding, which is kind of an inconvenient story, that antidepressant monotherapy in some people with bipolar depression is safe and effective. Maybe we'll talk more about that during the Q&A. 2 to 4 weeks. When you initiate an antidepressant in adult with major depressive disorder, you optimize the dose within 2 to 4 weeks if you're not observing at least a 20 to 25% reduction in symptoms as rated. And that dose optimization shouldn't hesitate. It should occur very quickly. And this has been a seismic shift in how we think about managing adults with depression today versus, say, 15, 20 years ago. Now, when I was putting the slides together, I was certainly cognizant it's early morning for many people. I'm always sensitive to the economy in the sense of the number of slides that we're presenting. And rather than going through dozens and dozens of slides on different antidepressants, maybe I'll just take a very pragmatic approach. And this is, in fact, one pragmatic approach that I often informally consider in my office. Most patients don't say to me, can you give me medications that make me overweight? Can you give me medications that interfere with my sexual abilities? That's not what people usually say. And that's usually what they prioritize as a non-starter. Also, 50%, if you believe the data from Guy Goodwin at Oxford, of people taking SSRIs and SNRIs report emotional blunting, a constriction of their affect when taking these medications. We're paying close attention to some of the differences across antidepressants in their ability to target key symptoms. It's often stated in psychiatry that all of the antidepressants are the same. I've never been really clear where that comes from. They're obviously very different pharmacologically, not only in their profile of safety and tolerability and drug-drug interactions and discontinuation syndrome potential, but also in some of their ability to improve select symptom dimensions, whether it be cognition or pain or anhedonia, or maybe other dimensions like panic disorder, obsessive compulsive disorder, and so on. But the key issue is that we need to be targeting key symptoms that are relevant to patient-reported outcomes. Many of you have heard me talk about for years how important it is for us to assess, measure, and target cognition in depression in bipolar. In fact, cognitive impairment in depression and bipolar is one of the principal reasons we see debased human capital potential and human agency actualization in depression and bipolar. The second of two suspects in my suspect line at the police station causing all this damage to functional outcomes is reward disturbance. When I was trained as a psychiatrist, anhedonia was taught to me as a unidimensional construct, the absence of pleasure. It's a bit more nuanced than that, and there are different subdimensions to anhedonia. We will see some patients who have disturbances in the anticipation of pleasure. Others, it's a disturbance in the experience of pleasure. But many experts in this area take the view, and I share that view, that one of the lesions in depression is not so much they have an anticipation problem or an experience problem, but they have a reward learning problem. That is, this functional and anatomical interconnectivity between cognition and reward is abnormal. You see this in obesity, we see this in diabetes, we see this in schizophrenia, and we see it in ADHD. This is a transdiagnostic construct and probably explains why so many patients fail to stay with the game plan during longer-term treatment. COVID-19 is certainly a chronic, unpredictable, stressful event. It'll be interesting to see what impact it has on acute and maintenance treatments in both depression and bipolar. We know from other lines of research that when you report trauma in your past as part of the anamnestic history, that attenuates SSRI response. Why? Because you're changing the biotype. Trauma activates the immune system. We saw that in those poor kids in Chicago. That also changes the phenomenology, disproportionately presenting with anhedonia and cognitive impairment, dimensions that don't cooperate with typical SSRI therapies. You don't need me to get on the call to tell you all the different antidepressants that we have. Most of them, in fact, offer some degree of benefit, but the reality is that it's rare that most patients can knock it right out of the park with full functional recovery. The most evidence-based support is for second-generation antipsychotics as add-ons in major depressive disorder. In our country, we have quetiapine, aripiprazole, brexpiprazole. There are legitimate concerns, of course, about metabolic hazards and weight gain, as well as short-term and long-term EPS, like tardive dyskinesia. And I certainly check for TD at every visit with an aims at baseline and periodically. Beyond that, we really don't have much of an evidence base. We try stimulants. We often will combine antidepressants together. We will often introduce medications like pramipexole and other dopamine modulators. But quite frankly, there's an urgent need for treatment-resistant depression to be met with treatments that are safe and effective. We define treatment-resistant depression as a scenario where the person has not benefited from at least 2 conventional psychotropic approaches. I have to say that psychiatry has been in a cul-de-sac for quite some time. That cul-de-sac no longer exists. There are some really innovative new lines of inquiry that are going on at the current time. The evidence around GABAergic drugs is really interesting, with the approval 2 years ago of brexanolone, the first positive allosteric modulator of GABA for postpartum depression, with the possibility of an oral formulation for non-postpartum depression very soon. I won't go through all of them, but I want to highlight orexins, and I'll come back to that a little bit in a moment. We are, in fact, looking at, in a study in the United States, orexin modulation as a potential antidepressant. No doubt about it that there's been a lot of streetlight shined on glutamate the last 10 years, and you've all heard about ketamine and esketamine, which Josh will walk us through. I just wanted to give you, if you will, a drop-down menu here so you can see the potential therapeutic opportunities afforded by simply one target. For example, dextromethorphan, good old DM, the antitussive drug that was actually discovered by the US Navy and the CIA. You go down to Shoppers and you buy some Robitussin with DM, that's dextromethorphan. It's also a sigma-1 agonist, a serotonin reuptake blocker. It's also a glutamatergic modulator. It's been combined with bupropion for a new antidepressant that is glutamate-based and will be approved in the United States a little later on this year. There are many others, but just give you kind of a sampling of how the science, the neuroscience around depression has evolved, and it's providing near-term actionable solutions for people affected by depression. Atul will walk through the story on orexins, his area of expertise, and I certainly won't encroach on that. But as a depression person and as a bipolar person, I love talking about orexins because orexins play not only a role in reducing overarousal, but they're also related to aspects of reward and cognition, the two suspects that are debasing the human capital of depressed patients. There are about a half a dozen orexin antagonists, whether they're dual or single orexin receptor antagonists, that are currently under development as potential antidepressants. So what's so exciting about the neuroscience is that it's just taken off in terms of us unraveling the mystery of depression and bipolar, but we have before us a dashboard of tens of thousands of medicines that we might repurpose, in other cases create de novo new molecules that will be genuinely novel, innovative, and target some of the key aspects of illness that hitherto have not been sufficiently addressed with conventional SSRI therapy. ECT remains the heavyweight champion of the world when it comes to efficacy. TMS does a lot better in public opinion. TMS is the one you like to have a beer with more than ECT. But TMS is not as effective as ECT in the most malignant phenotypes of depression. Notwithstanding, it's certainly much more acceptable to patients with a lower risk of cognitive impairment. In fact, we've recently added to this conversation by observing that in bipolar disorder, TMS may have pro-cognitive effects independent of its antidepressant effects, something also hinted at in major depression. I'm not a person who works in the area of neurostimulation. I'll defer to my colleagues there, but there's been a whole set of other types of options of neurostimulation that are taking off. This is one here called TD current stimulation. This is another modality of neurostimulation that's accumulating evidence of efficacy and safety in this area. The question when I started in psychiatry is, what's more effective, psychotherapy or pharmacotherapy? That's not the question today. The question today is, which is more effective for which symptoms? And we often combine treatments together, hopefully rationally. And what we found in this particular analysis, which I thought was quite interesting, is that when it comes to those key dimensional disturbances like cognition and reward, antidepressants beat the pants out of psychotherapy, and that's what I would have expected. In combining psychotherapy with a drug that can facilitate cognition and facilitate perhaps reward learning seems very rational to me, because psychotherapy is an exercise of practice and plasticity. And the exercise of practice and plasticity combined with medicine that facilitate plasticity in cognition and reward centers seems to me a very rational approach for many patients with treatment-resistant depression and patients presenting with chronic and episodic depression.